Okay, thank you. Good morning, everyone, and welcome to this meeting of the Ipswich and East Suffolk CCG governing body, held in public. And unfortunately, due to the COVID restrictions, we are limited to sharing our meeting with you through the ether and the benefit of YouTube. There will also be a recording of this meeting so that it can be viewed at another time, and I think available for up to a week or so. Is that correct, Simon?
Yes, it is. Yes.
Thank you. Again, welcome to the meeting. Joe, do we have any particular apologies for absence that have been lodged?
I've received apologies from Imran Badri and Steve Chicken.
Before we go on to the meat of the business, I've got two announcements to make. One is that we have with us in an observer role today, Fanwell, who is our new lay member for public and patient involvement. He'll be starting with the CCG on the 1st of December. So welcome, Fanwell, who will be doing his best to do the observation and probably coming up with lots of ideas for us to take on board. So welcome to you. The second is to let everyone know about John Oates, who's one of our GPs who's been on the governing body a little while now and has been involved much beyond being a GP in public service from the PCT through the CCG, really. And John is leaving us in the CCG to continue working as a GP locally, but leaving us within the CCG. So, John, I just wanted to say thank you for all the work that you've done at this level, for the leadership that you've shown and demonstrated in particularly the integrated care world more recently, and for the scrutiny you've given of the work that the CCG does and the feedback that you give to us all in terms of helping develop our leadership. So thank you for all of that work that you've done, and we wish you all success with the continued work that you'll be doing with us locally. On that note, I want to go on to declarations of interest and any hospitality or gifts. We do have a declaration of interest list that will be part of our agenda later on, that the CCG hosts, and we ask if anyone has anything additional that they wish to declare, or if there is anything specific within the items on the agenda that they wish to be known. If they have any conflicts of interest for? No, in which case we'll move on to the minutes of the previous meeting of the CCG to approve them as a correct record. Just wanted to ask whether anybody had any issues that they wish to raise about the accuracy of those minutes that were held on the 22nd of September. Paul?
Yeah, thank you, Chair. Page 4, I think first or second paragraph, where it talks about achieving all cancer standard. I think we may have said we saw some improvement to the majority of the cancer standard, not actually achieving all of them.
Okay, yes, that would be good to note. Thank you, Joe, if we can do that. Apart from that, anything else that anyone wishes to raise? In which case we'll make those amendments, and subject to those amendments, we'll approve them. Going to the matters arising and review of the outstanding actions. The first one, questions from members of the public, and reflecting back on the live streaming that we started back in May. Simon, is there anything additional that we've had feedback on? I mean, you said that to me privately earlier about the numbers that have been watching?
Yeah, so we started the live streaming back in July, and we tested the effectiveness of that. And September, we obviously promoted the live streaming and also the recording of the meeting. And I can report to the board today that during the last meeting of this board, we had 46 views of the live stream and also of the recording as well. So just wanted to feed that back.
Okay. And was there anything from any of the members of the public who've been watching say that they struggled with X, Y, or Z, or any comments that were fed back other than
we had one or two comments to say that there were some technical problems our end, which we have resolved and hopefully now have learnt from that, and we move forward with today's recording and live stream.
Thank you. Then 20073, there were questions raised around the dental costs that practice are bearing. For prescribing costs, which have been investigated and not been found to be significant. Maddie, did you have any other comments about that?
Apologies. No, we will be bringing a full paper back to the clinical exec either on the 1st of December or the subsequent week about our prescribing position overall. That will be led by our chief pharmacist.
Thank you. And then 086, the BAME work and the strategy. We've deferred the presentation to January. We have got a paper for approval in our part 2 about some support that we can give in the meantime. 088 from the Integrated Performance Report. Paul, do we have any update on the RTT? I've got something that I can comment on.
Yeah, so thank you, Chair. The communication plan has been drawn up, has been to the ICS board, has been to Tactical Forum, and Simon may wish to come in and comment here, but I've also asked him to, as requested, to circulate that plan to the executives.
Okay. I had a discussion with Angela, the medical director, the chief medical officer for ESNEFT yesterday about what kind of support can the hospital give to people as they're reviewing their position on waiting lists, particularly around trying to understand whether there's any additional support and other factors that may be influencing the health outcomes that people are getting, particularly around mental health, housing and household income. Just to see whether there's any additional support that we can get for people whilst they're waiting for treatment. The next item in there, Maddie, doesn't appear to have been a recent issue around access to COVID-19 tests.
No, I think we have a much improved position for staff across the NHS family, social care, care home residents and patients. So I think across the whole there is improvements. Yeah,
I'd agree. And then 089 Emergency Food Fund. There's an update in there. Do we still need to bring a report back? Do you still prefer a report to come back?
I think that we were advised, Mark, on this through the County Council that the funds that they had been given nationally were supporting access to a whole range of hardship support, whether that's about food or access to other support, for example, with utilities. So I think that that's in the safe hands of the County Council at this time.
Thank you. And then on the GBAF, there was a question around additional risks in respect of health inequalities, East and Brexit. It says there was going to be a discussion on the 9th of November. Do we have any particular update on those three things? And obviously the GBAF is on our agenda.
So shall I take that, Chair? So in terms of the GBAF, yes, we have that coming up. We did have a discussion at JLT. Health inequalities is showing, and I believe it's on the COO Direct at Risk Register, which Maddie may wish to update on.
Yes, it's on our risk register as the COOS for a coordinating function for the whole of the CCG, and it will also be listed in our alliance-wide risk register, strategic risk register, which we are currently updating.
Thank you. So we can take that off. And then question from the public. I'm assuming, Lisa, that the communication was made and we can take this off.
I haven't received any communication, Mark. I'm sure that Simon probably shared my details, but I haven't received anything from the member of public.
Okay.
We can follow that up, Mark.
Okay, thank you very much. Which concludes the matters arising. So Ed, over to you for a general update.
Thank you, Chair. And I just wanted to echo your welcome to Fanwell and your thank you to John for the amazing work he's done, not just on integrated care, but on a number of agendas, and also the superb work he's done with the public. I have fond memories of our discussions in Felixstowe. So thank you, John. So just a few updates from me, starting with some awards and recognition. So Julie Irving, who works for us in our digital team, has been named Information Sharing Champion of the Year for the NHS for the work she's done on My Care Record, which is a passion for this CCG. I think in particular, we've really promoted the sharing of information between professionals so that we can provide better care and outcomes for our population. So I think that's just a great tribute to Julie, but everyone that has worked with Julie on this agenda. And secondly, on SEND, the partnership from Health and Social Care and Voluntary Sector working on SEND have received a national award for their 16+ transition guide, which is very important for young people transitioning into adulthood. So that's very encouraging. And Lisa and I attended a session with the Department for Education last week looking at our progress around SEND, and there's some encouraging metrics such as our statutory assessments in this month are currently 96% vis-a-vis 42% a year ago. So we're seeing some real improvements in our metrics. The question is the impact for the families, and whether they're seeing improvements too, and that's what we really need to focus on. I wanted to reference the fact that we've had some excellent progress around our mental health crisis line, which Dr. John Haig from our CCG has championed and has worked on for a long time. So in the last 7 months, we've had 25,000 callers in Suffolk, and there's been some very good feedback about the service. I think that's absolutely excellent. We'll talk about COVID, no doubt, during the agenda, so I won't go into detail here to leave space for it later, but just to recognise a huge amount of work, ongoing work that we're all contributing in our member practices and our partners, but particularly in the area at the moment of COVID vaccinations, getting ready for the start of rollout in December, which has at least 3 aspects to it in terms of NHS trusts preparing to vaccinate their staff, and they're therefore trying to do as much flu vaccination in November to prepare the ground for the COVID vaccination, agreeing and securing mass vaccination sites in Suffolk, which the estates team have been doing really well, and then probably in the most complicated context is working with the primary care networks to ensure that we've got arrangements in place there, and thank you to primary care team for the excellent work they're doing with our members in that area. Allied to the vaccination, we've got the delivery of lateral flow tests being delivered to our trusts at the moment, which are effectively point of care testing kits for staff and patients. So we'll hear more about that as that arrives. So some really good news, but in both aspects. The comprehensive spending review is being announced, I believe, today, which is announcing £3 billion additional for the NHS, which will be used to address waiting lists, improvements in mental health care and diagnostics. We'll be talking in part 2 about EU exit, but just want to flag we're 6 weeks away from exit from the European Union, and there's a lot of work we're doing to prepare our contingency plans and our business continuity plans for that moment. And then the final 2 things is we're expecting legislation on the way in terms of an NHS bill, which we'll have more detail about either next month or in January, and we'll respond to that as that arrives. And then the final point was around population health management. A big thank you to Mark, who's been the clinical lead for that programme across Suffolk and North East Essex. And we had a brilliant event last week which showcased the work in our primary care networks. We had some excellent PCNs in East Suffolk, Ipswich and East Suffolk, who talked about the difference this approach has made for their population and for the way they operate and the way they work in terms of teams. And I thought that was genuinely impressive. So thank you, Mark, for your leadership of that agenda. So I'm going to finish there. Unfortunately, I have to leave to speak at the King's Fund, but I'll be back at 10:30 to rejoin the meeting then. So apologies for the interruption.
Thanks. Thank you, Ed. Going back to Julie Irving and her work on securing my care records, I can tell you that sharing care records so that clinicians can see the full record at the point of care they're giving patients that they may not know, so particularly in our out of hours or maybe in our A&E, can be one of the most effective ways of securing a safe outcome for that patient. So I can't tell you just how important it is that we've been able to secure that. And over the COVID period, where the collaborative working between all the elements of primary and community care, from visiting through to end-of-life care, was so important that we had access to those records. It was fantastic that we could do that. It really does make a significant difference to us. In terms of the flu, I'd also just like to add the significant large cohort of the over 50s that inhabit Suffolk, who will be then able to access a flu jab, even if they don't meet the current criteria, but really important that you don't all jump in to try and get one from your practice until it's time, which won't be until next month, and it will be through a calling process. So please be patient with your practice. We do want to be able to get you your jab, but we do have to do it in a safe way that helps us all. So please bear with us with that. So thank you. I'm going to move us on to our strategy section and start with our patient story. The patient story this time is around the care that our teams within intensive therapy units have been delivering to patients who've needed their care, particularly through the COVID time, but intensive therapy is there for those who need it no matter what the cause of their distress is. And the film that we're going to show you, we can only show you a small section of it due to the time constraints that we have. So we're going to show you the introduction to the work that our intensive therapy unit carers give, and how they go beyond the work within the unit in supporting patients in their recovery after they've received what can sometimes be weeks on end of care in sedated state. I hope that you'll find it as inspirational as I did when I looked at it. We are going to leave a way that you can link through to see the whole film in your own time. The care is amazing, but I'm hoping it will also inspire those out there who are thinking, could I do that as well? Could I be part of that team? Because I think when you see the film, you probably will be wanting to be part of that team. So I'm going to hand over to our Roll VT so that we can watch it together and then take any queries that we may be able to then pass back to our ESNEF team. And my thanks to them for providing us with this. Thank you.
There are a number of possible reasons why you may need to come to a critical care unit. And of course, every patient's experience and critical care journey is very different. We recognise from sharing events and clinic consultations that you will share some similarities with other patients. We know in the past that some patients will have welcomed the opportunity to have come to the critical care unit to see the environment that they were looked after in, and to make sense of some of the surroundings, maybe to hear some of the sounds and maybe even to see a familiar face. Unfortunately, in these times, that's not possible. So we've put together a short tour and informative video of the critical care environment, and we hope that you can watch it with your family and friends, and hopefully it will help fill in some blanks and help you on your journey to recovery.
Hello, my name is Maddie. I'm one of the nurses here on critical care. I'm going to give you a tour of one of our bed spaces. All of our bed spaces look exactly the same. During your stay, you may have had a specialist tube put down your windpipe, which is one of these here. This allows us to help you to breathe. You would have also been attached to one of our ventilators, which is over there, and they are all exactly the same. When you were ventilated, you would have had sedation, which meant you would be able to tolerate the tube and you would have been asleep. So after you had this tube, you may have also had a tracheostomy, which is one of these here. These would be put in your neck here, and this means that we can turn off the sedation so that you can be awake whilst you're attached to the ventilator. During your stay, you may have been attached to lots of different machines. This machine here records your vital signs, which is your heart rate, your blood pressure and your oxygen levels. You would have also been attached to our computer here, which is where we record all of our documentation. You would have also been attached to our fluid pumps here, which allows us to give you lots of different medications. You may have had lots of different lines inserted. So for example, you would have had an arterial line, which may have been in your wrist. This allows us to take blood samples and record your oxygen levels. It also allows us to record your blood pressure. You may have also had a central line or a vas cath inserted into your neck. One of them allows us to give you strong drugs, and the other one allows us to give you dialysis. You may recall lots of different noises and sounds. For example, our dialysis machine. This is very noisy and also uncomfortable. Some of the other machines that I've spoke about also make lots of noises, which you may recall. Whilst you're a patient here, you may have also had a specialist tube which would go down your nose and into your stomach. That's this tube here. This allows us to give you some special food and also your medications. You may also recall lots of different nursing interventions. One of them would have been regular repositioning, which would have prevented you from getting pressure sores. As you were getting better, we would have also started your rehabilitation. You may recall us getting you out of bed into a chair, which would help you to get better.
During the peak of the pandemic, many of the practices changed in critical care. The main one being when our patients arrived, they were already sedated and ventilated. Staff also faced challenges. These included wearing full PPE. Full PPE for our staff meant that they were wearing hats, visors, masks, full gowns and gloves. This presented many challenges for staff and patients, but mainly for patients, they were unable to recognise the staff who were looking after them on a daily basis. So the main roles and responsibilities of the critical care outreach team are to look after deteriorating patients on the ward. So we will receive referrals from doctors, nurses, other healthcare professionals. We will go onto the ward and provide support to that ward and bridge the gap between the wards and critical care. We prepare patients to leave critical care by visiting them on the critical care unit. We will provide them with information, literature to help transition that move onto the ward and make it just a little bit easier. We will also visit patients on the ward within 24 hours of discharge from critical care and just make sure that everything is how it should be and follow up on any concerns from the patients. Critical care outreach will assess patients on the ward by looking at many different things. So we will use tools to assess psychological impact from stays in critical care. We will also look at clinical things such as bloods, x-rays and other tests. Mainly we will liaise carefully with your parent team and bridge the gap between critical care doctors and also the doctors who are looking after you on the ward. While stepping down to the ward from critical care can seem like a positive step, sometimes patients can feel like a safety blanket has been taken away and feel quite lonely. Critical care outreach team aim to bridge that gap between intensive care and the ward.
So thank you so much for that taster as NEFT have provided us with, and I hope that you found it informative and whetting your appetite to be able to review the rest of it. Lisa, you popped your hand up.
The other thing I just wanted to add is that they also record individual patient diaries for when people are sedated, and if you're sedated for a long time, you have a whole missing gap in your memory of things that have happened. So they keep a diary for each patient that records who visited, what conversations that were held, because it helps people when they are recovering to make sense of some sort of snippets of conversations that they might have heard. So yeah, that's a really lovely thing as well.
Indeed. And any other reflections from any of the team here today? Pete?
Yes, it takes me back to a long time when I used to be an anaesthetic registrar working in places like that, and when I worked there was very little consideration given to the psychological aspects of an ICU stay, which we've increasingly recognised over the particularly with the increased numbers of people spending time in critical care during COVID. And I'd like to draw attention, we are in the process of setting up a pathway to help those kind of patients from the long-term effects of both critical care unit admission and particularly those that have experienced that because of COVID.
Thank you. Yeah, and I also remember those days whipping tonsils out while you were at the other end of the table, Pete. So thank you, and thank you again to the ESNEF team. Please pass on our thanks to them for sharing that story with us. I'm going to move us on to item 7, which is a review of the Felixstowe Minor Injury Clinic and the operating model there. All this is down to you, but I think I saw Nicola lurking.
Yes, thank you, Chair. We got Nicola Bunning and Matt Casey to walk us through the paper. Thank you.
Good morning, everybody. Nice to see you this morning. I've just had my tonsils removed, Mark, so that was a very a prudent comment. I'm delighted to be joined today by my colleague Matt Casey. Matt is the Operations Director from Suffolk GP Federation, who have been instrumental in implementing the changes that are outlined in this paper. So it's going to be a bit of a double act from Matt and myself this morning, if that's okay. So I'll kick off. The purpose of the paper is to confirm if the governing body is assured by the impact of the changes to the minor injury clinic operating model that were implemented from April 2019. I think it's important to stress that this paper has been co-produced by colleagues from the CCG, ESNEFT, Suffolk GP Federation and patient representatives from the Felixstowe community. So I think it's a fairly balanced summary of the impact of those changes. And just to remind everybody, there were 3 key changes that were implemented last year. The first one was to move from a walk-in provision where you could walk in off the street with your injury to a pre-bookable model. The second change was a slight refinement to the operating hours, reducing them to 8 a.m. to 8 p.m. And then, really importantly, the development and implementation of a frailty or ageing well service model for the Felixstowe population. So the scope of this paper reviews the activity relating to the minor injury clinic, outcomes, includes service user experience, an overview from the Felixstowe user group, and also a summary of the frailty work that's moved on since then. And then finally, some recommendations. I'm going to hand over to Matt now, who's going to talk us through the impact of the changes from a sort of an activity and service user perspective. Over to you, Matt.
Thank you, Nicola, and good morning, everyone. So as Nicola has mentioned, this report has been some work that we've both been proceeding with over the last couple of weeks and months. She's asked me specifically to cover sections 2 through 5 of this, which I will do now. So starting in terms of key outcomes, the report does cover the reporting information of the MIC. You'll be aware that the minor injuries aspect of the MIC is one of 3 key activities that are undergone right now. The other 2 are acknowledged in the annex as being phlebotomy and wound dressings. For the report itself for minor injuries, there are 11 key factors that are reported on in the service. This report acknowledges that 4 of them currently are unavailable. The reason being that the other 4 rely on a much larger reporting run that's conducted by TPP. The code for which is very, very large and requires custom software written to interpret and report on. That software is being written and is currently expected no later than January 2021. The report also acknowledges that there is a requirement to report on the type of condition types presented at the minor injuries aspect of the MIC. We're currently in the process of defining that, and that will follow in due course. Next, in terms of section 3, and importantly, the booking pathway, as Nicola mentioned, there has been some history to this. From April 19, GP practices could make practice appointments at the MIC online, and NHS could make them by telephone. And from February 2020, the Fed installed a new System 1 unit that allowed NHS 111 to book appointments online, which means that pathway is now existent and intact. Sorry, just one second. In terms of referral information, you'll see from the report that a total of 1,366 minor injury cases were seen by the MIC from April 2019 to March 2020. You'll note in the figures that there's always a fluctuation in that between summer and winter, with Felixstowe being somewhat of a resort. Summer numbers peak and it crashes off in the winter. It's particularly quiet at the moment with 81 in March due to COVID. Most of these cases are due to the local population, with 77% of referrals being referred from a Felixstowe GP practice, 10% being self-referrals, meaning people who walk in. It still happens, unfortunately, and of those, they were given an appointment. 94% of appointments were for people from the Felixstowe area, and we've defined that by the fact that they are registered with a Felixstowe GP practice. The DNA rate is very low. Normally, about 10% of people who are seen at the MIC would be followed up within the minor injuries treatment pathway. Lastly, in terms of survey user experience, a summary of it can be that the complaints that we have at the moment are currently related to DOS issues. There is some frustration within the patient community that they know the service exists, but sometimes the DOS will route them off somewhere else and tell them to go to Ipswich. But if there is setting aside that particular condition, those who do enter the service are very happy with what they receive. And that's backed up by the numbers. We've had 31 compliments and 17 related to DOS issues. Overall, I'm happy with the balance. Nicola, that's all I was going to say. Have I missed anything that you specifically want covered?
No, I think the summary in terms of the impact of the implementation, there were some teething issues, as you say, with booking and with the Directory of Services, but these have all been resolved, and broadly everybody, including the Felixstowe representatives, is content that the service model has bedded down nicely and is implementing as planned. And if that's okay, then I'll just pick up on section 7 in the paper onwards, which talks about some of the work that's been undertaken in relation to frailty. I understand frailty isn't a popular term, so I'm going to call it the Ageing Well Clinic instead. But in October 2019, the Ageing Well model was implemented, and the model is, before the pandemic, was led by nurse consultant Renee Ward, working and leading an MDT of health and care professionals to provide proactive support for people who've been identified by the GP practices in Felixstowe. Because of the impact of the pandemic, colleagues such as Rebecca Pulford and the Task and Finish group is reviewing options to be able to refine the model that was trialled in October, and for it to be able to achieve the right outcomes for our elderly population. I'm pleased to say that a geriatrician has been assigned to the clinic and is leading a falls clinic in Felixstowe. I might say it wrong, but I think it's Dr. Awais has been assigned to provide service and provide leadership into Felixstowe, which is fantastic. So I think it's fair to note at this stage that the work is still ongoing in terms of absolutely finessing and finalising the Ageing Well model and implementation for the Felixstowe community, which many colleagues from the Minor Injury Clinic are involved in supporting as well. So I guess the next section was from Alan Rose and Roy Gray, who are representatives from the Felixstowe community. We've been having conversations with them around how the changes have been implemented and embedded, and I'm pleased to say you can see in the paper that overall they are content and pleased with the implementation of the changes, and that it's gone down very well. I think there were just a few points that they wanted us to stress today, which I think is key. I think as Matt said, when we're talking about the Minor Injuries Clinic, we must remember the breadth of work that those clinicians undertake in that clinic. And in Appendix 1, which is at the back of the paper, it describes the activity levels for the same time period, i.e. for the year, for phlebotomy, wound management and minor operations. And just to highlight that the clinic undertook just over 8,000 appointments for phlebotomy alone during that period. So it's just remembering all the range of services that are provided by the Suffolk GP Federation within that unit, and to be cognizant of that. They also wanted to raise some concerns around the waiting arrangements, particularly as we're moving into winter period and elderly people visiting the unit had noticed people having to wait and stand outside. And I understand from Matt that colleagues of the GP Federation and others are looking at that to see what might be able to be put in place to make it more comfortable for our population. So I think really that's it in terms of sort of the key points we wanted to draw out today. And on the page 11 are the recommendations from the paper. And really the summary from the group that have been involved in this is that the changes have been well embedded, and that we ask you to note really the continued work around frailty and the development and implementation of that model. And the Felixstowe user group has asked for a publication of a brief annual report pertaining to the Minor Injury Clinic, and that was a recommendation that they wanted specifically to make within this paper. So that's it. So in summary, the clinic, a new pathway, seems to be going really, really well. And over to you, Mark, for any questions.
Thank you, Nicola. Thank you, Matt. I think it's going back to think about what were the objectives that we were setting ourselves when the national model for the delivery of minor injury units came about. And the things that I remember specifically were, how do we continue to support the assets that were available within the Felixstowe community? And secondly, how could we develop the offer beyond a safe minor injury service provision to include exceptional care for older people, and helping our older people team within ESNEFT and the community work with our practices to help roll out a model that wouldn't just be kept in Felixstowe, but would be available to all around the Ipswich and East Suffolk area, which it is doing. And I have to say, it is fantastic to be able to see that. And I'd just also like to mention that the World Health Organization has taken note of what's going on locally and has expressed interest, particularly in that care of the older person, and will be looking to see how they can also add value as a global organisation to what is happening in Felixstowe. And if that comes off, it'll be amazing.
Wow, that's fantastic.
John Oates, as somebody who sat alongside Ed and I at the public meetings that were held in Felixstowe, anything else that you would wish to contribute?
Only my deepest gratitude to all the players in this. We were handed what in sporting parlance is a hospital pass by the legislation when it came through, making it extraordinarily difficult to provide good value and quality care for the Felixstowe residents with the infrastructure we had. And I think we, by hook and by crook and through some very hard and difficult work, we've come up with a solution which makes the best of what we have, and is a fantastic potential platform to build the integration of care between our emergency providers, our hospital and bed capacity, and our primary care infrastructure. And I think that the Felixstowe hospital is where it should be in the community, and has a great deal to offer now and in the future for the infrastructure and social needs of the population of Felixstowe. And I think we should be rightly proud of the hard work we've put in and the achievements we've got from that.
Thank you, well said. Lorna.
Just for some sort of clarification about where the Frailty Clinic will be going. I look on the numbers, and obviously everything's been turned upside down this year with COVID, but the number of patients seen per month are actually quite small. How do you envisage that going forward? Because you know that the cost per patient must be quite high on that clinic. Could you expand on that, please?
I don't know if I can answer that in part. So my colleague Rebecca Pulford at ESNEFT has been instrumental in leading the model, working collaboratively with all stakeholders. And in the early days of the model, it was a soft launch, if that makes sense, to test the approach. So it was always the intention that in the first few months of the service that the model would have very few patients running through it to test out whether the way of working was efficient and delivered the outcomes that the group were hoping would be achieved. And I then think, as you say, COVID threw that all up in the air and has brought some further challenges. And I had an email, Lisa and I had an email a couple of weeks ago from Rebecca, who has reflected on the way the model had been operating and did note that in some aspects it was inefficient with a lot of clinical downtime, if that makes sense. So I know she's working with the integrated neighbourhood team to understand how that could be structured differently moving forwards to make the model more efficient and in turn to be able to see more people. But as I understand it, that's still in the kind of the scoping phase, if that makes sense.
Thank you. John and then Paul.
Just to be absolutely clear, I mean, not only in the minor injuries unit and in the frailty offer, it's not the numbers that we're after here. What we're paying for is an integrated service, so we're not going to get cost per value per patient in that traditional way. The cost per patient per value will come in the primary care interface at the work with the district nursing teams. So the frailty model over time, having discussed with the geriatricians last week, is going to be in the number of cases that don't need to be seen by a specialist service, because the quality of conversation around patients and the support that the primary care and the community teams, the therapy teams on the ground in Felixstowe get directly from the older persons services that are around the hospital. So I think it would be wrong to think about this as measuring quality by numbers of quantity. This is a quality piece, always has been, and the numbers that we're measuring are never going to show us vast shifts of activity from a hospital model to a primary care and community model. That is not the objective here. So it's an excellent question, Lorna, but the answer lies within a quality metrics, not quantitative.
Thanks, John. Paul?
Yeah, thank you, Chair. I was just going to make a very similar point that I think from memory, Section 8 of the papers talks about the fact it is an integrated model, and there are a number of other functions carried out by that team. Some of them are dressings, etc. So if the question is about the efficiency of the service, it is about the integration of the service rather than a specific question around the MIU itself.
Thank you. Lorna, is your hand up again, or?
No.
No? Okay. Lisa?
I think what would help the discussion is when we can move to understand the outcome measures of the population rather than looking at numbers of people and access figures, because as John and Paul said, it doesn't describe the journey and doesn't describe the avoidance of other costs in the health and care system that will have been experienced if we get this service right. So I know Rebecca is also working on that, looking at how do we describe outcome and impact so that we can kind of understand that rather than the access figures.
Yeah, no, it's absolutely right. So, I mean, in terms of the paper, I think we very much welcome it. Nicola, Matt, please give our thanks to the collaborative efforts that have gone on in the background, and again, welcome the inclusion of our Felixstowe residents in how this all comes around, because as Lisa has just articulated, it's the outcome for the population of Felixstowe and the impact of the model locally in Felixstowe and how it's rolled out to our other communities that will be key. So it's a great start, and we look forward to hearing more about it at an appropriate time where we can get to understand the outcomes and impacts better. So we look forward to that in due course. So thank you again.
Pleasure. Thank you, Mark.
Thank you. So where are we at to? Number 8. It's the commissioning intentions. Over to you, Richard.
Thank you, Mark. So colleagues will be aware that every year each clinical commissioning group needs to pull together a set of commissioning intentions for the next financial year. So last year we developed ours for Ipswich and East Suffolk with West Suffolk, and this year we decided that it would make sense, given the journey they're on around integration and working more closely across Suffolk and North East Essex, to develop a set of commissioning intentions across the three, so including North East Essex. As such, you'll see within the documentation in the pack that that's the process we've gone through over the last 3 to 4 weeks of developing a set across SNE. We followed the same process as we did for the last 2 years, where effectively we've moved away from, dare I say, a contracting and financially driven set of commissioning intentions to something that's more strategic and system by way of approach. So actually, you could say that this is a set of intentions across the integrated care system and the alliances, and less so a traditional set of commissioning intentions. And that's absolutely the intent to how we approach this. So the document itself sets out, firstly, kind of an overview of what is our integrated health and care system. And it starts with the context of COVID and the major impact that's had on us over the previous 8 to 9 months. And it starts really with those 10 key challenges that rose out of the review work that happened in the last couple of months to what we've experienced and what's happened. And I think starting with those and taking account of those over the next financial year is going to be crucial. We've then deliberately looked at our health equalities, or trying to achieve health equalities. So again, colleagues will be aware that's the major golden thread running through our ICS and alliance strategies to how we're going to do that. And again, we've talked here around the 8 urgent actions that NHS England have set out for all areas of the country to achieve. And again, that's going to be paramount in our work as we move forward in 21-22, and they're listed in the document. We've also referenced the importance of the voluntary care sector within our work as an equal partner, particularly as we tackle health and care inequalities across SNE. We've then gone through into our alliances, and there's a significant section in the letter related to each of the 3 alliances. And hopefully, if you've had the chance to have a look at them, there's a lot of synergies between the 3 in terms of how the 3 are working, how they're developing, what their priorities are, etc., moving forward. We've also focused on the localities, which is an incredibly important part of our architecture and our system. So those local, roughly 50k head of population geographic areas, of which we've got 8 in Ipswich and East Suffolk. Again, they're going to be a massively key feature of our work as we go forward, as we start to work with each of those localities on further developing and implementing their local delivery plans for the local population. So we've always started on that before we even get to the CCGs. So there's a small section on the CCGs, which effectively reinforce that we've moved over the last year to a single accountable officer and management team of officers across the 3 CCGs. It talks about our exploration of the potential for further joint working across the patch, both with the county councils, the districts, but also as 3 CCGs. And colleagues will be aware that we're in the process of working through what that might mean in terms of the actual architecture, the setup of the 3 CCGs. We've included, like last year, a bigger section this year on the primary care network, so the PCNs. Obviously, they further developed over the last financial year, and there's going to be absolutely key deliverables now that the PCNs are working through. So we've set what some of those are. There's a small section deliberately, what's called aligning incentives to deliver change. So this is effectively the contractual and the financial section. Partly the reason it's small is that at this stage, we're still waiting for the phase 4 guidance that is due to come out from NHS England. So phase 4 is effectively what's the next stage of our planning work across the NHS, which will run from March through probably to the following financial year, 22-23. That usually comes out Christmas Eve. So that's a nice Christmas gift every year for us. It may be slightly delayed. We're still waiting to understand exactly when it will come out. And also, as Jay may come in later, the financial position has obviously been variable. I think it's fair to say over this financial year in terms of how much understanding we've had of our finances and how that can be used. So it's almost a holding position there until we get more guidance. And then effectively it goes through all of our major transformation programs, either at ICS level, alliance level, or even county level. And it sets out what the major deliverables that we're expecting over the next financial year to achieve. And then it finishes up, rounded up with the enablers, so workforce, estates and IT/digital, and sets out the context of what our deliverables are there. So it is a bit of a weighty tone, but hopefully the covering paper gives you really a snapshot of our main intentions going through. And then final thing to say is that we're working with both Essex and Suffolk Health Watches to develop a much easier read version of this that will be front facing on our website and our other communication, alongside the actual letter that is a formality effectively that we have to send out to our major providers. And we're aiming to do that once the 3 governing bodies have gone through this. So end of next week, we'll be sending it out. Thanks, Mark.
Thank you, Richard. So yes, a very clear focus on the outcomes we're looking to achieve, not just the list of actions for procurement, as was tradition, and how we corral all the assets we have to deliver that. Maddie?
Thank you. So I just wanted to say a little bit more about the Alliance plan and to ask that we bring a full paper, which I'll be pleased to write, to the next governing body, both on the deliverables of the Alliance, and as far as we can, the outcomes of the Alliance over the last period, and also on the future development and plan. So just to add a little bit more detail to the actual intentions.
Thank you, that would be welcome. Good. Any other questions that anyone wishes to raise, observations or comments? I know that we've seen this in a number of different arenas. Thank you. So thank you, Richard. Thank you, the team, for the style in which this is being delivered and the intent, rather than all the list of intentions. I think is a very welcome change to the usual methods. Thank you. I'm going to move us on to item 9, Connect for Health. Maddie.
Yes, and I'm going to be pleased to hand over to the experts, Dr. Dean Dorset and Louise Hardwick. Thank you.
Yeah, hello. Yes, so we'll be taking you sort of quickly through this paper. We'll be doing a bit of a double act where I'll take you through the whys. Louise will take you through the future on what we're doing now, and then we'll hand over to questions. So essentially, this has been through the sort of prescribing work stream, through clinical exec, and also through the Alliance, and has been sort of well received. Essentially, 80% of what we do is impacted by the social context of what we're doing. This has been a national exemplar, and over the last year or two has probably saved an estimated probably 1.93 or above. We are sort of quite excited because it not only gives us this vertical integration that we're after, but it potentially has the ability to give us whole system-wide sort of integration as well. So I'm going to hand over to Louise to take us through the nuts and bolts, and then we'll come back and finish off.
Thanks, Dean. Good morning, everyone. So nearly 2 years ago, Ipswich and East Alliance co-produced a social prescribing strategy and delivery plan in partnership, including 3 patient representatives. I think it's safe to say we were an early adopter of the scheme and have met a lot of challenges on the way, which you have definitely learnt from. I'm pleased to say that the Social Prescribing Board has gone from strength to strength, with many of our Alliance partners having a seat at the table, with issues and decisions being discussed in a real co-produced way. As alluded to, I think we were clearly ahead of our time with social prescribing, and it is now national policy for every primary care network to have access to social prescribing, and that social prescribing also forms part of the wider element of the personalised care agenda, in which this will be seen as business as usual across the health and social care system by 2024. As our scheme, as Mark alluded to, is called Connect for Health, and it has 2 elements. That first element is the connector, or the social prescribing link worker, and that is the social prescriber, and that currently is provided by our voluntary sector organisations, and a community chest for activities. And those activities are like prescriptions in the community, again, working alongside our voluntary sector. We currently have 16 whole-time link workers across, and they are covered in each of our INTs. Each has been through a comprehensive training plan, which is constantly evolving, particularly over the last few months due to the pandemic, and also part of a network of support which has proved really invaluable. The service has seen over 5,600 clients over the last 2 years, and each of those people have had a personalised plan and a Warwick and Edinburgh score completed at the start and end of their engagement. And the qualitative feedback we have heard is overwhelmingly positive. It's really pleasing and encouraging to see that during the pandemic, all our alliance partners have used social prescribing link workers to support their patients to build health and well-being, both during the crisis and now going forward. We've seen a really large increase in the workload and the pressure due to the increased demand for social wellbeing support as a result of the pandemic, and the programme of work has evolved to accommodate that. We have linked social prescribing link workers with the discharge hub at ESNEFT alongside the rehabilitation of COVID patients, and now concentrating on high intensity users. The social prescribing link workers have also supported the Collaborative Communities Board and the Home But Not Alone service further, which alongside our local authority colleagues. This is definitely not a static linear service, but a real growing opportunity. For example, we're now working with our transformation colleagues and ESNEF to support those patients on the elective care waiting list. We've recognised that patients are waiting longer for their planned operations and will need more holistic support. Our local model is seen, as Dean has just alluded to, as national best practice, and as such has attracted other opportunities, bidding for additional bids for personalised care, links to learning disabilities, creative health hubs, and now our new BAME social prescribing service. We've now been able to have that umbrella strategic oversight of linking underutilised NHS properties to social prescribing, evolving our borough and district councils in our work, as well as ESNEFT and NSFT, understanding the VCSE in terms of funding opportunities and partnership working, including community-based assets and volunteers. Our bid for funding to link social prescribing those with learning disabilities has recently been successful. I'm pleased to say that this will see a small cohort of the population who have a learning disability and who have no access to digital devices to receive a grandpad to enable them to speak to family, friends and carers, but also to enable them to have primary and secondary care consultations, including annual health checks, and even order food, medicines and shopping online. Since last week, I've had discussions with Public Health Suffolk to link in their new initiative that sees exercise classes with resistance bands being posted to the population of East Suffolk, with social prescribing linked with annual health checks and those with learning disabilities, and those patients who are on waiting lists for elective surgery, and those who've been discharged from hospital after a stay or recovering from COVID-19. We're working on further 2 applications alongside alliance partners in the voluntary sector and local community groups for further funding from the Arts Council for Thriving Communities money, and through other community and through the Community Realisation funding, which is the NHS Charities Fund. The total CCG investment in 2021 was 700,000. To note, we've aligned alliance resources, which have included local authority community chests with that, and the community development officers' time to link in the work alongside our local communities. Suffolk Community Foundation have also aligned grant funding to help with connectors taking patients to different services and giving them that warm handover. One of the real learnings is the monitoring evaluation of service. It's recognised that there's been a huge investment in the programme in both setup and now operations, and unfortunately there's no national proxy for return on investment that we've found. We've asked providers for almost all of the metrics we need to assess this, but in realistic terms we now need to mandate this collation and ask some further questions to complete a full evaluation. I'd like to take this opportunity to make a couple of thank yous. The first must go to our 3 patient representatives, which are Mike Golding, Wendy Turner and Keith Redfern, who have been working alongside us over the last two years and continue to do so as being our critical friend. They've been instrumental in giving a patient perspective in everything that we do and have given up their time selflessly. A second thank you to our social prescribing link workers and our providers who've really stepped up during the pandemic for their proactive, innovative, hard work and tenacity over this period. And lastly, for me, a personal thank you to Dr. Dean Dorset for his strategic leadership and support over the last couple of years to ensure that our model is seen as a national exemplar and being sustainable and scalable, moving with different times and demographics. So what are the next steps for Connect for Health? We really would like to consolidate the service as a cradle to grave service, encompassing all our different areas, mental health, children and young people, and definitely those seldom heard. To differentiate the service based on need from a basic referral within the community, which is at bronze level, to a full health coaching and support service, which is a platinum model, as per the illustrated model within the slides. To bind in that personalised care and personalised health budgets, and to further enhance the monitoring and evaluation. So the ask today from the governing body is to agree to a 1+4 year contract, which will give a strong signal to all our partners and our current providers that we intend this to be a 5-year contract, subject to further improvements in our monitoring and evaluation. So to invest £792,000 this year, of which £660,000 is invested in social prescribing link workers hosted by our voluntary sector. £120,000 is invested in community chest for prescriptions and £12,000 to be spent on IT, the System 1, to help really embed that monitoring and evaluation. But we also recognise that there is more opportunity to work close with our primary care networks and co-produce a suitable service for them to support their priorities and requirements, linking with their delivery plans and population health needs, and a desire to encourage a strategic shift to addressing inequalities. Back to you, Dean, or the Chair, Mark, and we welcome any questions from the board.
So just quickly, because I know Mark is running sort of behind time, and it's just one comment on the timing of this. We couldn't have predicted when we decided to go for scale that this would be so needed during the time of COVID. And as it is now, with the effect that COVID is having now, with what it's exposed on inequalities, and with the effects it will have on our populations and those most vulnerable in the coming sort of decades, I think we are very well placed. I'm also mindful that there's a 40 to 60% of the voluntary care sectors who are at risk, and our kids who we need to step up for. So I think in a lot of ways we're quite well placed, and the fact that we can have a unified offer at scale that helps every part of the system integrate, I think is not only useful, but I don't think we can do without it.
Thank you, and thank you both, and thank you to the teams, and as you said, Louise, the patient participation as well, that's helped make this the exemplar that it is. A great example of working and attempting to get evaluation built in to work hand in hand to deliver the outcomes we're looking for. I just wanted to acknowledge the work at Tower Hamlets. The one team development programme and Sam Everington's practice in Tower Hamlets, I think, did act as quite an inspiration to local GP leaders, particularly around the benefits and getting that early sight of what social prescribing really could do. I think has also put a bit of oil in our engine on social prescribing and helped it get that lift off. That's been great. So the paper is asking for that 1+4 contract approval with the outlined finances. Any other comments from the governing body about that? I know the clinical exec were very supportive. No additional comments. I think you've said it all. So I'm taking silence as the fact that we will approve that recommendation. Maddie?
Just to also emphasise the support of the alliance partners. I mean, it was universally all well received. So thank you, Louise and Dean, but it really was a whole system positive response to this. And I think that's immense in itself. It says a great deal about the way in which the service is valued.
Indeed. And John's comment rightly made in the chat. So thank you for the paper. We'll make that approval. So thank you again.
Thank you very much.
Thank you, Louise. So moving on to the procurement update, Paul.
Thank you, Chair. As you will notice, the paper is to note and is simply a record of the current procurement activity which is happening currently. I would just pull out maybe 2 or 3 things out of the paper, and just to note the mobilisation of stroke early supported discharge contract, which is great news given the fact we've tried several times to get that mobilised and procured. So really great news. I would also probably pull out the mental health transformation piece, which is going through its current assurance process, expected to complete on the 30th of November, with a view to a paper coming to the January board in terms of outcomes. And finally, given the conversation around social prescribing important, the piece around BAME activity and 113k grant to support social prescribing moving forwards are probably the 3 key aspects of the paper I would pull out. I will simply ask the board to note the paper. Thank you.
Thanks, Paul. And being a bit close to the stroke piece through the chairing of the ICS Stroke Board, I have to say that the teams that make up the Stroke Board really do recognise the opportunity, not only of what has been procured, but also the opportunity of how it's built upon and extended. So it's not just about stroke, about brain injury and about rehabilitation, not just for the early supported element, but beyond. So I think the opportunity is great. Thank you. Any comments from our board today? Thank you. In which case we'll note that paper and move on to item 11, the Emergency Planning, Resilience and Response Core Standards Audit. Paul again.
Okay, thank you, Chair. We are required, should I say, to note progress against EPR at least on a yearly basis, and essentially this is a paper that actually does that. I'd like to say just a few things, if I may. Clearly, we were written by an HSE advising us what our role needed to be this year. We were informed that it's going to be a light touch approach, in so much that it was simply a review of the previous year's plans, with a view of the action plans being in place rather than looking at actually completion of plans was the approach this year. The only other thing I would say is clearly the element of 111 and practice group were nationally reviewed rather than locally reviewed. And you'll note from the tables that we went from not assured essentially to substantially assured. So again, that was very much a national approach. So again, just to say, light touch approach, it was EPR peer reviewed on the 4th of November, and the table essentially highlights the progress that has been made to date, and broadly substantially assured all the way through, which is great news given what we've been through in terms of COVID pressures. The only apologies I would make is that I think on the tables, the third column I think should say 2021 and 1920, but we'll make sure we make the amendments on that page paper. So essentially, the board just simply has to note the progress against the PRR.
Thank you, Paul. Yeah, I was going to ask for that clarity on the years on the table, so that would be good if we can just have that amended. Any questions from the governing body? So yeah, we welcome that report and the improvements that appear to be there from an EPPR perspective, and also the impact, seeing it in real life with COVID, unfortunately, but nevertheless a good test of our readiness. Thank you. I'm going to move on to item 12, the SEND annual report. Lisa.
Thank you. So we took the SEND annual report through to Clinical Scrutiny Committee and had a good discussion on it there. So it's just being brought to governing body for information, really. You'll see that from the logos on the paper, it's a report that goes through to all partners' boards, and the report details not just health, but from education and social care as well, against our strategy. It gives an overview of the governance arrangements, and there's lots of detail in there around what's gone well, current concerns, and the areas that we need to continue to focus on. The strategy obviously ends this year, so we were well on way pre-COVID to developing the new strategy. We really want to co-produce the new strategy, not just with our children, young people and families, but with our frontline practitioners and workforce as well across social care, education and health. And we are starting that piece of work again. We really want to make sure that we have a good strategy that's fit for purpose to give us the direction that we need over the next 3 years. So we're tackling the new strategy with renewed enthusiasm, and hopefully we'll have it to bring to governing body in March. Thank you.
Thanks, Lisa. Any questions from governing body? I think I'd certainly welcome those investments that have been made, and certainly again agree with those concerns. I think how as the public sector we work with our schools will be so vital in terms of the issues around the exclusions and the impact of mental health generally, as we know, within transition, but also, the impact that COVID's had on family life as well will be so important. Dean, you popped something in the chat. Lots more work to do to help our youth and those voiceless and most in need. Indeed. Anything you want to add to that?
Not really. I was just responding to John's compliments. I don't think we can rest on this success. There's lots more to do, and the aftershocks of COVID are going to ask a lot of us.
Yeah, indeed. Thank you. So if there's no other comments, we're very pleased to welcome the report, receive it and note it, and support you with that desire to see a good, strong co-produced strategy to help take this on even further. Lisa, thank you. And it remains the Lisa Nobe show with item 13, the COVID-19 vaccine update.
Thank you. So obviously COVID-19 is the kind of theme that goes through the whole agenda, really. So I thought I would bring a verbal update because everything changes so quickly with COVID-19 and the vaccination programme that actually writing a paper by the time we brought it here would no longer be applicable with the rate of change with things. So I think there's two areas that I will just update on, if that's okay. The first one is the outbreaks within our health and care settings, and the second one is the information that I can share on the COVID vaccination programme. So for outbreaks in health and care settings, we have seen a significant increase over the last 2 months, which is putting some real strain on our health and care sector. We currently have in Suffolk 13 outbreaks, 9 of which are in and East. And in our acute sectors, we also have a number of outbreaks, less in West Suffolk, more in Esneft. Esneft 2-site organisation currently have 10 outbreaks in their teams and clinical areas. So the way we manage that with our acute sector is we have what we call infection management team meetings with the microbiologist infection control teams. My infection control team and I and my deputy team attend. It's chaired very helpfully by Paul's team in the Instant Control Centre, which is great. And we have those 3 times a week just to keep track on the actions and make sure that we are all agreeing on when areas can be reopened and the infection control and prevention processes that our acute trusts are taking. There's a similar process for care homes where again we have multi-agency oversight of the actions that they take to ensure that people remain safe and outbreaks are reduced. But we are seeing more outbreaks, and each outbreak has obviously a root cause analysis completed. I think probably the most significant root cause tends to be asymptomatic staff, which obviously we now have the lateral flow tests that are being rolled out to our acute sectors, which we believe will significantly help with reducing that. It's all about test, really, to reduce these outbreaks. So the other area that I was just going to give an update on is obviously the COVID vaccination programme, which has been in the media both locally and nationally over the last few days. So as you will all know, we have 3 COVID vaccines that's been developed with really promising efficacy. So Pfizer and Moderna, and now the 3rd vaccine, the Oxford AstraZeneca vaccine, is also showing some promising results. So the vaccinations will be delivered in 3 ways. We will have fixed, what we're calling mass vaccination centres. We will have mobile centres, and we will have a roving service for housebound patients. In Suffolk, partners have been working hard to make sure we can start vaccinating as soon as we receive the vaccine. As you'll know, it's not licensed yet, but we are getting ourselves into position so that as soon as the vaccines are licensed, we're able to start deploying. We've been asked to get the first site running by the 1st of December, and we're on track to do that. That doesn't mean we'll have the vaccine, but we'll be in a position to deploy as soon as we can. We've then been asked from the regional team to establish 16 other vaccination sites across Suffolk and North East Essex. So we are quite a good way into establishing and understanding where those vaccination sites will be, taking particular account of making sure that we have them in areas where public transport are an issue, and to make sure that there's equity of access for all. The other model that we'll be using is through our primary care groups, and primary care have also been working really hard to make sure they're ready to start vaccinating whenever we get the green light to go ahead. So that's been a huge amount of work in a very short time to get ourselves up and running. The phased targeting of priority groups isn't finally defined. It will obviously start with our most at-risk groups. Dependent on the vaccine that we actually get will depend on the priority groups that we target first of all, and that will be a national direction. So I think that's probably the end of the update that I'm going to give, but I'm obviously happy to take any questions, or if anybody else, we're all working on COVID-19, so I'm sure everybody will want to give an update. Thank you.
Thanks, Lisa. I've got a number of hands up. I'll start with Maddie.
Thank you. So I was just going to make 3 quick points. The first is that we have stood up again the Alliance-wide cell to support management of COVID and winter. So that includes our partners from ESNEFT, from primary care in and out of hours, our mental health trust, our local authority colleagues, amongst others, as well as CCG colleagues, obviously. So we meet every week and we consider the issues and risks and the ways in which we can mutually support one another to mitigate those. So just to share that. Secondly, in terms of primary care, I mean, obviously staff within primary care also have been affected by COVID. I would say again that the IT that was provided in the first wave has been so important and so helpful to enabling business continuity. So a huge thanks to Amanda and her team for enabling that on behalf of primary care. And yes, thirdly, just to thank practices for the work that they've already done to respond to the national ask in terms of identifying sites and teams and ways of working that could meet the national specification for delivering the COVID vaccination. So I think people have worked so fast to get to that position, and we await national feedback and our next set of instructions, which we will again follow with rigour and pace, I'm sure. So they're just 3 points. Thank you.
Thank you, Maddie. Lorna and then Paul.
It's just a comment, really. I think that it's really good to hear how everyone has worked so hard on COVID and tried to get the vaccine out. I mean, when we think that the scientific community really stepped up and what should have taken 10 years took 10 months, I think that it's now our turn to really step up and say that we can do this, we can deliver the vaccine. And I'm really pleased to hear how hard everyone's been working and how much progress they've made. I'd say, well done.
Thank you, Lorna. Here to that. Paul?
Yeah, thank you, Chair. I just wanted to pick up just a few points, if I may. Just really a big thank you to the infection control team. I think we can't underestimate the impact that's having, given the fact that at any one time a trust site can lose 40 to 50 beds because of an outbreak on a couple of wards. And really to recognise that actually our acute colleagues are working incredibly hard in very difficult circumstances, maintaining elective and emergency flow through the hospital, given the challenge that we're having. And finally, the point around the Alliance, absolutely crucial in terms of support and being to flex on a day-to-day and week-to-week basis to maintain all the services. So it's just a recognition of all the hard work that's going on to keep the emergency flows going.
Thank you, indeed. So the challenge is not to get complacent in any sector. Demob fever can be very tempting when we've got a sight of a potential end through mass vaccination, but the speed at which this virus can spread and take out communities is something that we have to remain very vigilant about. So, the strong message about stick with it, Suffolk, is still there. We want everyone to stay safe. So please do stick with it. We strongly recognise the challenge to deliver the vaccination with teams who are tired from being on high alert for many months now with this virus. And in addition to a whole new vaccine being delivered, we've got the extended vaccination programme for flu as well. So really an enormous amount of work in addition to the recovery and the maintenance of business as usual. this is very challenging. We recognise it, and we thank everyone out there who is working their socks off to get this delivered. Because, as you say, Lorna, we owe it to the science community who've given us this opportunity. The vaccine doesn't work unless it's in somebody's arm, and that's what we need to do. And being prepared is what healthcare professionals want. I don't know how many of them were Boy Scouts or Girl Guides, but I think probably lots of them. And we want to ensure that what's delivered is safe and that it's delivered safely. We believe in prevention being better than cure. This is an amazing opportunity to do the prevention, and it's so important that we do it safely. So we need cool heads. Those cool heads need to give us some clear plans, and those clear plans need to be clearly communicated. And the actions that we take, the patience you have to give us in order to do this safely, and I'm speaking to our members of the public here particularly, please give us that space to be able to do this for you safely so that we can give you the protection as soon as we can, because that's what we want to do. We don't want to hold it up. So thank you for your patience. We are looking to ensure that we deliver that in spades, so that we can do the protection for you as well. So stick with it, everyone. Thank you. It's 11:15. What I propose that we do is put Jane under an enormous amount of pressure to do her paper in 10 minutes, if she can, so that we can all then have a 5-minute break. Over to you, Jane.
Okay, thank you, Chair. I will accept the challenge. So it's been a very interesting year for NHS finance, but I'm finally pleased to be able to bring a budget for a fixed proportion of the year, which hopefully we'll be able to work within as a CCG. So the paper presents the budget from October to March, but so the second 6 months of the year. This paper has been reviewed in detail at the CCG's Financial Performance Committee. So I'm not going to take you through lots of the ins and outs of the detail, but I'm going to provide you with a really high-level summary. And just to say that this paper concentrates on the key allocations for the CCG for the remainder of the year. It does not include any expected expenses around the mass vaccination programme, which are being looked at centrally and worked on very hard with our partners across the region. Neither does it include anything around the recently announced resources for primary care, or anything that comes out in today's spending review. So it's the kind of core budgets that we are working to for the remainder of the year. They will change for those elements. But as you can see in the paper there, we've been issued with an allocation for the second part of the year. It's been quite a complicated exercise to get to this, but in summary, it's an allocation which is a business as usual type allocation, which has been supplemented by additional resources for the system to deal with the COVID response for the second part of the year, as well as a small amount of what's called growth funding, which is approximately 0.5% of system allocations for us to do everything else that we need to do. So what you'll see in the paper, there's a summary of how those resources are proposed to be allocated. They're basically to pick up a lot and continue to fund a lot of services that we put in place in the first half of the year, as well as new ongoing areas such as Think 111, where the national funding has not been sufficient to cover the resources. So it's a real mixture of things that we're covering in there, but that's all set out in the paper. The good news for Ipswich and East Suffolk CCG is when we've been through and projected forward the expenditure, looking at the trends in the first part of the year and the anticipated changes for the second half of the year, we believe that the resources that we've got will cover the expenditure sufficiently. So we've been able to pull together effectively a balanced budget for that second half of the year. That's not without its risks. We obviously know that we were preparing this budget before we significantly went into the second wave. But notwithstanding that, we believe that the CCG should be able to live within these resources with those caveats that I gave at the beginning. And you can see the paper sets out the amount of resources that we've got and the kind of key areas of expenditure across our main headings of acute mental health, community, etc., that as we're normally used to dealing with. So I'll come on to when we talk in the finance report as part of the integrated performance report what's happened in the past, but this is about the budget going forward, where we've moved away from that system of central top-ups and effectively accessing a national budget for all our additional expenditure to moving back to this more normal local budget. So that's the first part of the paper, is effectively to present the budget that's been looked at in detail by the Financial Performance Committee, and as I say, is a balanced budget. What I wrapped into the paper, rather than putting in lots of other separate papers this time, were other things that, again, if you've been attending or watching the governing body, you'll be familiar with happening this year, just to deal with the extraordinary circumstances that we found ourselves in. So we put in place a specific committee and a sort of emergency committee to deal with all the additional expenditure and the fast decision making that we've required across our CCGs and across our system. That's the COVID Approval Response Committee. We want to extend that. I'm proposing that we extend that committee until the end of March, because we've got some particularly fast-moving, let's say, decisions to be made around the mass vaccination programme, which will need to be dealt with on almost a day-to-day basis, rather than waiting necessarily to bring things to governing body. So rather than just roll that forward for 2 months, which I've done in the past, I'm suggesting that we put it in place till the end of the year. We obviously will not use that committee unless it is required, but if it's there and it's set up, we can use it when we need to do so. So that's the second recommendation, is around the extension of the committee, and the third one, to run alongside the resources committee. Effectively, we want to. I'm proposing that we continue the extension and the increases of our delegated limits. It really just allows that COVID resources committee to do its work, so that it can make decisions which might be above normal resource levels that we would normally bring to the governing body, so that we can make those decisions quickly. But effectively, the assurance for that is that we report all of those decisions through the Finance Committee, and you'll see later all the minutes for that committee come to the governing body, so that you can see in a fully transparent way all those decisions that have been made. In reality, there have been very few times that we've actually used those enhanced limits, but it's really just there to make sure that if we do need them for the remainder of the year, they're already approved, and we don't need to come back to the governing body for that. So that's the paper, the recommendations, Chair, and happy to take any questions.
Thank you, Jane. Very succinct, and thank you for that. So any questions from governing body? I've got a couple of queries, which may be just more information, really. We were going to be audited, Jane. Is that underway, or have we had it, and expecting some information to come back about the decision making that we've been taking in the early months of the pandemic?
No, absolutely, Mark. Well remembered. So Ipswich and East was selected in the second round of a series of audits that's been undertaken nationally, looking at the response to COVID. We are still we're close to finalising the audit on that, and hopefully we'll have the report back in time for the audit committee in December.
Excellent, thank you. My second question was really sort of extending beyond that. You know, we obviously take our responsibilities very seriously and want to play our part, but we are part of a system, the system of Suffolk and North East Essex. How do you feel we are? You know, what sort of confidence do we have that we think we'll get to a system balance at year end, given the budget that we have?
So if we look at the wider system, rather than concentrating just on this individual organisation, there are a range of different plans which have been submitted. So there are organisations that have submitted balance plans, and that includes our partner CCG in North East Essex. There are, however, across the system, organisations that haven't been able to submit balance plans. Now, that's for a range of sort of technical and operational reasons and specific pressures that are occurring in some organisations. Our partner CCG in West Suffolk at the moment has submitted a plan that is out of balance. The resubmission of that has reduced the amount that's out of balance, but it is still 3 million adrift. And we will need to work as a system to look at our overall expenditure and if there is any capacity for the system to effectively do slightly better than our plans, that will be extremely helpful. But at the moment, the plans have been submitted and accepted by region, and the idea is that we work to those plans to try to improve on those where it is where it is naturally easy for us to do so. There's not any expectation of making any drastic savings in the particular period that we find ourselves in. However, we do, as always, just need to continue to be financially prudent, make sure that we're achieving best value out of everything that we do,
whilst supporting the best performance we can manage and the highest quality.
Absolutely.
Thank you. Well, I don't see any other hands up. So it's coming up to 5 to 11. Thank you, Jane. We can have a 5-minute break. So I propose that we'll start with the integrated performance report at 11 o'clock as per the agenda. So take this time to have whatever you need to get through the next section. Thank you very much. So it's 11 o'clock. I'm going to propose that we restart our agenda at item 15, which is the integrated performance pack and report. So I'm hoping Lisa, Paul, Richard are queued, as well as our GP leads for the appropriate point. So who's going to start us off?
I'm happy to do so, Mark, if you want me to, in terms of general observation of the report, if that's fine with you. Okay, so if I start essentially with the CCG performance itself and some of the key aspects of the report, you will see that 18 weeks is showing some marginal improvements, about 7 to 8%. That we're starting a very slight increase in 52 weeks, but though there is evidence that that is slowing down. Diagnostic is improving slightly. And the other issues for me is that clearly we're in the context of growing waiting lists still. The only point that I would make, though, is that this report is September's report. And since then, we've had the kick-in of phase 3, which is about increasing of activity and capacity within our acute sector. And already, although the information is not on the report, we are seeing some improvement in 52 weeks in some areas. We are seeing some improvement in 10 to 13 weeks wait in diagnostics. So again, my expectation as we move forward is as capacity is sustained, we may see some improvement in some of the more urgent cases that we see. That doesn't negate the issue of capacity versus demand, which is a slightly more longer term issue. The other point that I would also make is we are starting to see performance also through the lens of winter. And again, what we will start to see, I suspect, is slight deterioration, for example, in any performances, etc., because the system is on significant pressure. We will clearly see some workforce issues, sort of, filtering through that may affect performance. But what I can report is that at the moment, as we stand beyond September, our organisation have managed to sustain the gains that they have made in terms of capacity, which is great news given all the challenges that they are facing. So that's essentially the RTT element and the elective sort of element of the piece, really. In terms of cancer, I think there are some useful green shoots, shall I say. 2 weeks seems to be improving slightly, although I would point to the performance at SNF and West Suffolk, where SNF is showing slight deterioration, whilst West Suffolk is showing 65% 2 weeks, which is primarily due to diagnostic problems around endoscopy. And again, we are working with the to try and see if we can improve that position. And it's direct consequence of direct to test the pathway, and that's what's being demonstrated here. In terms of 31 days, we're doing okay. I think we're maintaining, but clearly the elective element of that is the element which is underperforming. And you'll note, I think, on the NF element, 42% around breast. That was primarily due to capacity issue, and I'm glad to report they've addressed that issue by putting additional list. And my understanding that it currently stands in they have caught up on the backlog and now maintaining the 14 days. So some assurance around that bit of it. We are seeing some slight improvement in 62 days, but I'd like to point that as trusts sort of start to catch up on the backlog, I am expecting to see a deterioration in that 62-day performance for the sheer fact that they are now processing and managing and treating patients that have been waiting a long time. So again, looking forward, great news to see a bit of improvement 62 days generally, but I would expect possibly to see a deterioration on that. The only other three things that pull out of the report is that you'll know that East Suffolk community in terms of performance around the CYP and SALT is not performing as well as we might expect. But I would point to the transformational programs to underpin that work and the effort that have been made to try and improve that element of the performance. You will note that ESEC is performing slightly less well than it previously did. What I can report on that is we've recently agreed some additional resources to support that through the winter. So hopefully we will start seeing some improvement and some close working. And again, EAST from an ambulance point of view is showing slight deteriorations. But I'm glad to report that regionally, I think from the figures that I saw yesterday, they hit all their markers for the region. I can't yet tell you what it looks like for East Ipswich and East, but it's certainly they would certainly do a lot better given the pressure they're under. So that's a brief summary, really, I think, of some of the key points for me in the report. And I guess some of my colleagues may want to bring out some of the transformational and quality issues and financial issues that may emerge out of that report.
Thank you, Paul. So shall we just move straight on? Lisa, do you want to?
Yep, sure. So I guess the main area of quality oversight that we have with our trusts is obviously around the infection prevention and control agenda, not just COVID, actually, because if you look through the plan on a page for each organisation, a number of our trusts also have ongoing cases of C. difficile, MSSA, bacteremia, E. coli. So again, it's making sure that we don't forget everything else that's going on, and we keep our oversight broad and pick up on other things. So the IPC team, as well as keeping oversight of all the outbreaks that I talked about earlier, are also supporting the trust with the other hospital-acquired and community-acquired infections, of which at ESNEFT there are a number which is detailed on the provider on a page. I think the other thing just to raise at ESNEFT is their flu vaccination rate. So we have an East of England average for flu vaccination at 63.1%, and as at 18th of November, ESNEFT were reporting 56.4% against a 90% target. So again, looking at how we can support, there has been some supply issues, and I know that there's a lot of oversight from the executive team on the flu vaccination, but we will be expecting them to improve those figures to make sure that their staff have been vaccinated prior to COVID vaccination becoming available. As you'll know, there has to be a 7-day gap in between flu vaccination and COVID vaccination. So I think that's probably all. Oh, the only other thing is the Never events in ESNEFT. We are still seeing a number of Never events, and we have asked the Trust to come and present at our clinical scrutiny committee next week on their action plan. Next month, sorry, December. Thank you. I'll hand over to Richard if you want to raise anything around ESNEFT or that programme.
Thanks, Lisa. So just some headlines from the elective care and the integrated care programmes related to Ipswich and East. Obviously, we cover this under the ESNEFT banner of acute and community. So just building on what Paul said around elective and outpatients, the week ending 15th of November, ESNEFT saw 97% just over on ordinary electives, so the inpatient electives, and 92% on day case. So they're doing comparably well there are percentages against the levels of activity pre-COVID year on year. So you can see that even in the challenges Paul outlined around now into the winter demand pressures, the Trust is holding its own around continuing to keep its elective activity going. And similarly with outpatients, they're running at higher on firsts. So they're actually now at 103%. So they're doing more than they were last year on firsts. And on follow-ups, they're at 90%. So again, a strong performance back in terms of what they're seeing. And just to be clear, as part of that, that's not all face-to-face follow-ups. There's a significant increase in the proportion that is now done virtually. And I think, as a colleague said in an earlier item, that's one of the good points, I guess you can put it like that, from what we've experienced is the significant increase in rollout of virtual consultations, both in primary and secondary care. It started to dip slightly, I think, as we're bringing more face-to-face back. So the overall volume is increasing, therefore the proportion that's virtually slipping slightly as it's increasing. But nevertheless, that's a good performance. We've now started the recruitment of the additional phlebotomy staff. You'll recall through the executive, we had a challenge in terms of the sheer volume of phlebotomy appointments that were needed. So that's now starting to ramp up. and also the work on the 4 big areas of elective around patient-initiated follow-up, virtual consultations, advice and guidance, and telederm are going well. And Pete and I had the elective care board last week to oversee those developments. On the integrated care side, so urgent emergency care, community, etc., just to pick out a few headlines. So one of our major focus areas at the moment is around meeting the 2-hour urgent response in community and the 2-day response in terms of reablement. So they're 2 now priorities that the regional NHS England team are focusing on all systems on. You'll know within Ipswich and East, we've been working on this for years, if I'll be honest. So the fact we've already got the REACT model out in terms of admission avoidance, with the 2 hours as being the standard, and the discharge to assess work that we've been doing with two days being the standard. I'm not saying there's not challenges, but we're starting from a solid base that the teams are working on. I'm pleased to say that we've got the initial draft of the Frailty framework, so it links back to the earlier item in part on Felixstowe that Nicola, John and colleagues were talking around. So we really want to start ramping up the work in Felixstowe, but also starting to widen that out into Aldborough and other parts of the Ipswich and East patch. So we've got not just a frailty hub within the Ipswich hospital site, but we're actually starting to proactively manage ageing well, as Nicola said, as opposed to frailty out on our community basis. And then finally, pleased to say all but one of now, I just like the word camel lifting. So all but one of our care homes has now received the camel lifting training. The one that hasn't has declined, but we're still working further on that home. And we've also invested in 50 beds out in community services to the end of March to provide additional capacity for flow, particularly over the winter period. So I'm pleased that we've managed to now mobilise that as well. But they're the main headlines linked, I guess, to ESNEF, both acute and community.
Yeah, thank you. Thank you all for that. Pete, you've switched your camera on. Were you going to add anything particular before I go into questions?
Just a couple of things. I think Paul and Richard have really covered most of the aspects. I think in terms of the elective care, just echo what Richard was saying about we're working with ESNEF on the alternative modes of consultation, looking increasingly at using advice and guidance as the preferred method of outpatients rather than necessarily face-to-face. We're setting up a GP forum with Angela Tillett, Medical Director of ESNEF, to make sure there's much better communication between primary and secondary care on elective care. On the cancer side of the ball, I'll steal Richard's thunder by saying ESNEF in September actually gave more first patient treatments for cancer than any other trust in the country, which I think is a considerable achievement. That's not necessarily going to be reflected in the waiting times, but in terms of numbers of people being treated for cancer, ESNEF actually is top of the Premier League at the moment, and I think that success needs to be acknowledged. The symptomatic breast performance we recognise, and we're going to be doing some work with secondary care to try and improve that. The telederm service that Richard mentioned is for skin lesions being very successful and is returning almost 50% of referrals back to primary care without needing a secondary care appointment, which I think is a great success. And as you know, we're expanding to work that into two-week waits. A lot of the innovation that we paused during COVID, we're beginning to restart. Particularly, we're looking to launch the Rapid Diagnostic Centre, which has been paused, and we hope to get that off on the ground and seeing patients in the next month or two.
Thank you. Lorna.
Thanks, Mark. This is sort of business as usual, really, and it's a question for Lisa around the maternity services, which I know we've been looking into a lot, and have also been, everyone's been looking into maternity services a lot. September last year, the NHS published a study from Scotland into 74,000 births with patients who were looking about whether they were going to have a VBAC or a repeat caesarean section. And the results are quite interesting. Babies who have the repeat cesarean section, only 6.3% needed to have interventions with equipment and NICU afterwards, whereas the VBACs had 7.99%. So quite a difference, especially with our priorities of wanting to give every child the best start in life. And I would be really interested to look down into that a little bit more in ESNEFT, and I would particularly want to know what the consent is to the mother about having a VBAC, and whether there is some written paperwork about it. And I would really like to see what they're informed about when they try to do a VBAC. You know, I think that's a really important issue. Is that possible for Lisa to look into that?
I can just in case there's any public watching, VBAC is vaginal birth after cesarean, and I can certainly look at that, Lorna. We do oversee the cesarean rates quite closely, but not the VBAC, if I'm honest. So that would be a good area for us to do a bit of a dive into. Thank you.
Okay, thank you for that. Any other questions around ESNEFT, or shall we move on to West Suffolk?
Yep, sure. So, I mean, it's actually a similar situation in West Suffolk to ESNEFT. So, again, less outbreaks than in ESNEFT, but obviously smaller organisation. And they also have other infection control challenges as well. We're doing a programme of QA visits into West Suffolk. We've done the meds management one most recently, which gave good assurance around the safe storage of medicines. So that was good. And we are planning a visit to look at the support given to people with learning disabilities through that pathway, and also mental capacity assessment. That's probably my key anxiety about West Suffolk that we would like to test. The other area that we're also going to, we've just recently in the CCG recruited a children's lead, and we are going to start doing some quality assurance visits to the community paediatric service. We know that they were rated as good as part of West Suffolk's overall service, but we do have a key number of items that we would like to pick up from the paediatric community service in a quality assurance visit that have been highlighted through incidents and investigations that we've done. But other than that, supporting the teams on their outbreak management. They haven't got an IPC lead at the moment. That's probably the key risk that the Director of Nursing would highlight if she was here. They haven't been able to recruit an infection control lead. They do have a very good infection control team that have been in infection control for a long time. So from a knowledge base, they have a great team, but actually being able to recruit into that leadership post has been a challenge for the Director of Nursing. So we are looking at potentially a different model that may provide some of the leadership capacity, but pull on the technical expertise from the microbiology team and her infection control team. And also flu vaccination. So at the 18th of November, they were at 58.9% flu vax, which is again below the East of England average. So working with them on that. Thank you.
Thank you. And Richard, Paul, anything else to add?
Just briefly, most of the same messages that we gave for ESNEFT are equivalent in the West, but just to give you the percentages on electives, the current performance is 81% and day case 69%. So they're running slightly behind ESNEFT, but there are particular challenges with the site that we're aware of and capacity more broadly. But we've got the similar programme to we outlined, Mark, with ESNEFT in place. And indeed, we had the elective care group meeting at 8 o'clock this morning, Helen and I and others, to go through where we are with that. Think 111 first, forgot to mention it earlier, that's launching on the 2nd of December. So we talked here previously about effectively our integrated urgent care service provider, so 111 and GP out of hours, will now be providing additional capacity to hopefully move additional walking activity that goes to A&E through into Think 111 first, and then they'll determine how they're best seen. And then just to follow up from Lisa on the community paediatric service that West Suffolk FT hosts, we had a deep dive meeting on Friday to look at where the teams have got on the community services, community paediatric service review that we're in the second phase of. So I'm pleased to say that they are really thinking very creatively around how we can develop more of an integrated children's nursing model across acute, community, primary care. So they've got some initial ideas, but we're looking to have some further workshop sessions with wider system partners in the new year, excuse me, to further how we can create a more integrated model. And then we're looking to move on to therapies and medical effectively, because at the moment it's almost like they're sitting in a bubble, so to speak, and it's how can we create finally more of an integrated physical health children's model, linking then to the mental health work we're doing in CAMS as well.
Mark, so apologies. The only thing I would add around West Suffolk is that they are, in terms of diagnostics, they are bringing online additional CT capacity with MRI capacity hopefully in January, so that will help. But really the main focus is going to remain endoscopies, and we're having discussions with them in terms of the future plan, how we might seek to improve that.
Okay, thank you. Any questions from governing body in West Suffolk, in which case we can move to NSFT.
Sorry, so NSFT, not a huge amount changed from the last time we gave an update. They're still maintaining their great performance with inpatient learning disability areas, and really doing some good work with us and Suffolk County Council on the LD transformation bit. The children and young people and families care group continue to really try to understand their position and the improvement work that they are doing, and actually attended the DFE NHSE monitoring visit for SEND with us, and really assured the NHSE national advisor on SEND around the processes that we are taking for the neurodevelopmental pathway work and their assessment of waiting times. And as you'll see on the provided on a page bit, there's some concerns that we have around eating disorders pathways, but again, there's a full programme of work going on with eating disorders, so we'll just wait for that to finish. But that's probably all I have to raise. Thank you.
Thank you.
So there's a huge amount going on in the mental health programme, and it's incredibly exciting. It feels like it's really motoring now, famous last words. So on community mental health, we finally have a more of a detailed community all-age mental health model that NSFT and the GP Federation with ourselves have co-produced with our co-production partners. And there is a series of meetings happening with the Primary Care Network clinical directors to look at how we can further develop that model and actually start to make some commitments around staffing, workforce, etc., to put it into place into the early part of the next financial year. So I'm really pleased, after a lot of groundwork to try and get to this point, we've now got, I think, something that we can take forward, which is great. And that's gone into NHS England last week, as they were asking all areas to set out their community mental health model to be able to elicit some transformation funding, which is great news. On mental health crisis, we're now in the assurance process that Paul's leading on, effectively to ensure that we're happy or not. Hopefully we will be. No pressure on NSFT and partners, that we've got a model that we're happy to confirm, and that will be coming through to the governing body meeting in January, hopefully for a final decision on. We've got a number of business cases that we're in the process of developing that will be coming to a conclusion in December and January. There's one on personality disorder, which is an incredibly important part of the jigsaw. Those who have heard the consultant lead, Lulu, talk about that, and John, there's a huge amount we need to do in terms of the demand that's out there that has potentially a trait of a personality disorder that we're just not managing well. Lisa's already referenced eating disorders. So there is a proposal coming through being developed around the whole eating disorder pathway in terms of what that could look like. And there's also a business case coming around the further expansion of the IAPT service. So effectively, there's a national ambition to get up to 30% access within the next 2 years. We're currently commissioning at 25%. So that will be coming through for a decision probably to the governing body in January. So huge amount of work happening. Should say children's also, not to forget children's. We've also finally launched the long-awaited neurodevelopmental and behaviour support package procurement, title I've just come up with, which is effectively going out to the market to seek voluntary care sector and others support around pre and post diagnosis support to children, their carers and families, which I think is incredibly important. Remember, we agreed across the two CCGs £700,000 of recurrent investment in an incredibly important area of our work. So that is started. So I'll be really excited to see what comes out of our initial engagement with the voluntary care sector. And I'm also pleased to say that we've also reached agreement with the County Council and NSFT. This is led by Leanne and Lisa's team with Gary and mine around the CYP crisis service model that we were spending some time debating, and they're now at the point of now going out to recruit the leads for that service. That's another really important element of the work that we're doing that the governing body previously agreed investment to.
Thank you. Paul, you popped your hand up.
Yeah, just to add a bit to that, and just to reassert that either myself or my team member are now attending NSFT Finance and Performance Committee directly. I think that's usually helpful for a number of reasons. One, it's more direct access to the board, to non-executives, and we're having a really good conversation around some of the issues. Two, it allows us to influence more directly, which is really, really quite helpful. And not that we should ever doubt it, but also to report that there is a high level of internal scrutiny around performance at NED level, which is always useful to understand. So as by reassurance way of looking at it.
Thank you. It's good to hear, and as you say, hopeful that that would be happening. I haven't got any other hands up in the from governing body members. I just wanted us to be reminded that there is a significant coroner's investigation at the moment around eating disorder deaths in Cambridge and Peterborough, which of course has included Suffolk residents. And we need to ensure that any report that comes from that on the prevention of further deaths, we need to ensure that we've got the ability to accommodate any recommendations that they're making. Richard?
So we've had an initial discussion at the Regional Mental Health Board a couple of weeks ago where Tracy Dowling, Chief Exec for the Cambridge Community Trust, was talking through this. There's going to be a workshop organised, hopefully fairly rapidly, about taking more of a regional approach to eating disorders, because there's a risk that each part of the region goes off and develops, and we're part of that, developing our own eating disorder service model. And we've also got the Mental Health Provider Collaborative forming, which is effectively all the mental health trusts in our region coming together to take delegated responsibility for specialist mental health, including eating disorders. So we're trying to bring everyone together to take stock of the learning from the coroner's report, and also where each of the SDP ICSs have got to with this work, to come up with a broad model or an oversight of what that could look like.
The multi-agency, multidisciplinary approach is going to be paramount, and particularly the role of primary care clinicians within that. You know, we've debated that within our own one team approach between our primary care GPs and NSFT teams as well. So, you know, it is complex, and we know that it's not going to be simple. Thank you. Anyone else want to make any comments? In which case, shall we move on to the Practice Plus group? Can we say that that's the name for what was Care UK?
We can. I haven't really got anything further to add to what's in the PowerPoints. I don't know if Richard wants to.
No, other than what I'd already tried on Think One first. Most of the rest of it's business as usual now with this.
Yeah.
Yeah. Okay. Any questions? We've got ESEC. You mentioned earlier about performance for ESEC and looking at what kind of support, given the issue of infection prevention control with COVID, is having on transport. Any questions? Shall we move into East? Again, made mention about their performance.
Yes, so from a quality point of view, East obviously have a great regime of support from the national teams. We now have the East Oversight and Assurance Group, which there's representation from each ICS within the East of England to make sure that as commissioners we are collaboratively working with East and NHSEI and all the other stakeholders that attend the OAG arrangements. So they are currently working to a bit of a new leadership regime at the moment. So Tom Davis has stepped into the interim chief executive role at the moment until the end of the year, and they have a newly appointed interim director of nursing, Juliet Beale, to support them to make the improvements to quality and particularly on the safeguarding processes. We do continue to have oversight of their safeguarding processes, and as we have felt in the last few months, they are making some really good strides with that. Also IPC, we're doing a deep dive into the IPC arrangements. One of their key risks is between staff members not following guidance when they're in cabs and in the coordination centres. So as a group of commissioners, we're going to test that within our own localities. But that's probably all I've got to say on quality. They have a huge amount of support from the national team, which is really well welcomed, and they're working really well with the national team and the improvement team. Thank you.
Thanks. I did notice on their CQC that they haven't had a patient feedback for about 7 years. Just wondering whether they might need to do something more in terms of getting some feedback from the people that they serve at some point.
Okay, I'll have a look at that.
Any questions from our governing body? No hands up. In which case, I think we can move into primary care, Maddie.
Thank you. So I was just going to make 5 points. So the CQC, the position remains the same, that they're not currently doing full inspections of practices. In terms of SMI health checks, we've, I think in the context of COVID, made some really good strides. And in fact, in the kind of highest group in the region, in fact, I think nationally in terms of health checks, dementia is more of a concern. And I think there's 2 things going on in our position per se and our position in terms of the region. So obviously during the first wave, very few people were attending practices and diagnoses being made, and that also applies within the NSFT context. So in addition to that, so positively, the other areas have improved, and they have been working with an organisation who have been supporting a review of patient notes and a review of coding. It's incredibly complex, some of this coding, and so we're going to try and learn from that and discuss that with practices as to whether that would be supportive. Prescribing per se, well, you can see the numbers. We have a very significant financial gap. We have a plan to kind of mitigate and to try and address some of that. I think it's appropriate to say not possible to close that total gap in this financial year. So practices have many things on their minds, and they have responded to patient needs. and that's absolutely the right thing to have done. We now do need to make sure that we're doing all that we can in terms of managed repeats, in terms of items that may have remained on prescriptions for safety, quality and cost reasons. So the team is actively leading that work. And the fifth point, just to mention, is that we do now have the Primary Care Commissioning Committee did approve the temporary list closure of the Claydon and Barham surgery. It's a small surgery, but we took that on safety grounds. We will be developing with them an action plan to enable them to reopen their list. So just for everybody's reassurance, and particularly the public, this just means that no new patients can register with the Claydon and Barham surgery. They will continue to serve the people who are currently on their list in the usual ways. So there are other surgeries within the broader country community that will be able to register those patients. So I'll leave it there for now, but I'd be very happy to take any questions. Normally I can give you a good plug for the Primary Care Commissioning Committee, but there isn't one this month at this time, so don't tune in because we might not be there.
Okay, thank you. I don't see any hands up, in which case I think we can move on through to the finances, Jane.
Yes, thank you, Chair. So we're reporting in this pack on the financial performance up to the end of October. So for people who were listening intently earlier, the first 6 months were part of the sort of nationally mandated regime, and so month 7 is our first month of being in our new allocations that we looked at earlier. What the report does is it's trying to report on this quite complicated financial situation that we're in. So what it does is it shows both the expenditure against our allocations and how much the CCGs have received or are due to receive in terms of top up. So obviously month 6 was in the centrally managed regime, so we are still waiting to receive the month 6 top up for the CCG, which is 3.2 million. We hope that will come through in the next couple of days. In terms of the new regime, whilst I said earlier that most of that is down to allocations that we deal with locally, there is one element which was set out in the budget paper, which is the hospital discharge programme. So this is a particular funding stream which was put in place to really help to both support admission avoidance and hospital discharge between social care and continuing healthcare, which the CCG looks after. And so for the first 6 months of a patient's care, rather than deal with that in the usual ways, splitting that between social care, the CCG and self-funding, that's funded from a central pot called the Hospital Discharge Programme. And for month 7, we do anticipate claiming some funding from that, which is shown in the table. But overall, once those reimbursements are received, the report is showing that both for the month that ended at the end of October and for the year we're forecasting that we will live within our resources. The report goes on to give you a little bit of a breakdown of the overs and unders in there, and obviously that does include that prescribing pressure which Maddie spoke about earlier. We anticipate that we'll be able to absorb that within the budget as a whole, but obviously the work that continues on that is part of our financial strategy for the year and going forward. The final slide just gives you a breakdown of the year-to-date expenditure that the CCG's made on COVID overall, and you'll see by far the largest category for that is the hospital discharge programme at just shy of 13 million. Part of the reason why that's so high is that Ipswich and East Suffolk is the host for Suffolk County Council, so we're picking up and asking for national reimbursement for the costs for the whole of Suffolk in there. So it does look slightly disproportionate, but that's just a way of trying to streamline the bureaucracy associated with that programme. So that's all I've got to say, Mark, unless there are any questions.
Thank you. I don't see any hands up, so that's great. Thank you, Jane. So that concludes our integrated performance report. So we're going to move on to the governing body assurance framework. Graham, anything that we need to have our attention drawn to?
Thanks, Mark. The only thing I can see on the GBAF that hasn't been raised is around maternity issues, and it's around the birth rate plus scheme. Actually trying to get the funding for that and the workforce. So I don't know if Lisa wants to say anything.
Yeah, sure, thank you. So ESNEFT, we've supported ESNEFT with their business case for Birth Rate Plus, and that went to their divisional management team meeting a couple of weeks ago and is due to go to board imminently, which is asking for some significant investment into midwifery staffing to support Birth Rate Plus. But Birth Rate Plus isn't just about maternity transformation. Birth Rate Plus is about making sure that you have enough workforce to deliver a safe service. So with that business case is imminent, and West Suffolk are working on their business case, and again we're supporting them with that. They do have Birth Rate Plus, but because they are a smaller unit, it's difficult to deliver the continuity of carer model even with Birth Rate Plus, because they're a smaller maternity unit. So you need a higher number of staff above Birth Rate Plus figures, which is quite interesting.
Yeah. Thanks. The only thing I'd say, Mark, is that the other key points are listed in section 2. So other than that, I've got nothing else to add.
Okay, and no hands up querying about it, in which case can approve the framework as it stands. I'm going to move on to item 17, the Health and Safety Risk Committee. Amanda.
Thank you very much, Chair. So here we have our usual update on all things health and safety regarding our CCGs. And as members will see from the report, we last met on the 29th of October. Since that meeting, we've now extended the membership to cover North East Essex CCG as well, which is a positive step in the right direction in terms of how we collaborate as a team. So as we can see from the report, just a couple of things to draw out. Number one, the COVID risk assessments for all of our buildings in which we occupy have been updated and completed, and we just keep a watching eye on those as we move forward to make sure they are up to date, and we also publish those on our intranet site for our staff. In terms of flu vaccination for our CCG workforce, ongoing work continues with our occupational health department, and as of yesterday we have now 100 members of staff that have been vaccinated. We have further clinics this week and indeed going into next week, so we're hopeful that we can get better compliance across all of our 3 sites. And in terms of our home working policy, we have just enhanced to reflect not only the RA process, but also ensuring that we give support to our staff in terms of workstation risk assessment so that they can have a proper workstation set up from home. And as yesterday, we discussed as a director team what the new world might look like post-Easter when we're able to go back to our working offices and working practices. And we have assigned the organisational development group that works across our 3 CCGs to look at home working, working in the office, and how we can maximise our remote working through Teams still. So lots to look forward to and enjoy, and I'm sure I'll be bringing an update to governing body in due course. But happy to take any questions, Chair.
Thank you. And any questions? I don't see any hands up for you, Amanda. So
thank you.
Thank you. So we'll receive a note that report, in which case we go again with Amanda into declarations of interest.
Thank you very much, Chair. So this is a report that we bring to governing body twice a year. And as we can see, it's an updated, or as far as we can update it, of all of our registers and declarations of interest. And I guess the one question I would invite governing bodies members to reflect and maybe comment on perhaps after this meeting is how we can work further with primary care to get a more up-to-date position of our declarations of interest, because as members will see, we do have a few gaps at the moment, and it would be great if we could actually close the gap so we have more declarations of interest duly noted. So that would be my plea, but very happy to perhaps work with Maddie outside the meeting. Thank you.
Yeah, thanks. What I've done with Suffolk Primary Care and previously when it was just So Health, was to try and keep a register that was kept up to date, so that when the request for the register came through, everyone had their up-to-date interests within the practice, to which they then added whatever personal interest they had. So it was more around how we try and get some systematic approach to that, because it always seems to come as a shock that people have got to declare their interests every time.
Absolutely.
You know, it's something that happens on a routine basis. I don't know if anyone else has got any other magic ways of doing it. No, doesn't look like we have, but we'll work together on that, Maddie.
Brilliant.
Yeah.
Really happy to work on it, and pleased on a personal level to confirm that I have now refreshed my own. There was no change, but I note that we have to completely do it. I think maybe we need to take a different tack, Mark, exactly as you say, and work with the practice managers. I think for many who are not kind of involved on a day-to-day basis, there's such a kind of a distance from it that it doesn't seem to be the priority that we maybe need to request that it is. So we'll try a different tack and work with Claire Pemberton and the practice managers and see if we can implement the methodology you've suggested. Thanks.
Okay, yeah, it's how real it feels, isn't it? Okay, thank you. In which case we'll go on to item 19, Jane, appointment of external auditors.
Yes, thank you, Chair. So people who were at or watching the last meeting will recall that we updated the governing body on our process to go out for an external audit contract. And pleased to say that we have subsequently we've been through the procurement process, and we have a successful firm that we would like to appoint for starting from the audit of this year's financial accounts, so effectively to start with us in the new financial year. So as the governing body will remember, we appointed a panel, as we're required to do, to oversee the process. The panel looked at the results of that tender exercise and agreed with our recommendation to appoint BDO as our new auditors. That will be across the 3 CCGs that make up Suffolk and North East Essex, and will really help with help to smooth the process of getting the accounts completed in that very tight timetable that we work to each financial year end. So I'd like to basically make that recommendation, and hopefully governing body will agree.
Yeah, thank you. So it is to receive and approve. As you say, the team you work with, Jane, do an exceptional job every year in getting the accounts to the line in exceptionally smart order. So yeah, I'm sure BDO will have their work cut out to match their amazing abilities there. So are we happy to, sorry, carry on?
No, sorry, and all I was going to say, but just huge thanks to Graham and the audit committee who've been closely involved in that.
Yeah, thank you. So I am taking the fact that we have no additional questions, that we're happy to stick with our original approval. So thank you very much. So moving on to item 20, terms of reference for the Commissioning Governance Committee, Amanda.
Thank you very much, Chair. So this is an update, and for ease of reference, the changes are shown in red, and it basically is to facilitate how we're working virtually at the moment. So I would be happy to commend those revised terms of reference to the governing body this morning.
Okay, did anyone have any questions about that, Maddie?
No, I was just going to say it makes perfect sense. It's a minor tweak and it's still a really essential committee for us.
No, absolutely.
Thank you.
Yeah, a very supportive one. Thank you.
Thank you.
Brilliant. In which case we'll go on to item 21. We've got the list of minutes of meetings that have taken place. Graham, that has your name attached to it. Is there anything else?
No, the minutes speak for themselves, Mark. Thanks, Craig.
Yeah. Maddie?
So I was just going to add two things. It's normally a quiet session. One is, I think it might be useful if the meeting notes, the board minutes from the Alliance came through now fully and formally as part of this set. And the second thing is just to say that the Community Engagement Partnership has continued to meet on quite an informal basis over Teams throughout the period. So there's not the same kind of formality as usual, but they have continued to meet for reassurance. Thanks.
Thank you for that. And I mean, we're going to talk about the Alliance and where it sits within the governance of the system. So, you know, as integral partnership and an integral demonstration of partnership in action, the minutes would be quite rightly should be there for us to see. So thank you. Which brings us to the conclusion of our meeting. So thank you all for those contributions and the timeliness that everyone has been able to display today. We've got a date of our next meeting as the 26th of January 2021 at 9 o'clock. I am assuming that once again we will be doing this virtually. I think it would be difficult to declare otherwise at the moment. And we've got still take questions from our public once we've had the opportunity to publish our papers. Simon, I believe we've got a couple of questions today.
We certainly do, Mark. Thank you very much indeed. The questions come from Anthony Dooley, the first of which is, could you get clarification of how many people with learning disabilities will have access to hardware to enable them to use it to have GP appointments, including annual health checks?
Addy.
I don't think we know that answer at the moment, but through the work that Louise was talking about, that's supported by the region, by working in partnership with key community organisations, I think we will begin to get a good idea. So, interesting, I don't think it's a standard question at the moment in an LD health check, but that might be something that we could consider. But as I say, through that other work, I think that we will start to have a really good indication. And it is absolutely our intention that we will offer individuals that would benefit most the opportunity of these iPads, they're like iPads that will enable people to do many things, including have a GP consultation.
Thanks, Maddie.
I might be able to answer even better and further.
No, not about hardware, I'm afraid. I was just, my mind was thinking about how we have to join up all the work with people with learning disabilities to make sure we demonstrate impact and outcomes rather than just always focusing on the number of people that have had the check. How do we link it up with all the rest of the LD improvement work, with the leader reviews that bring out root cause? So sorry, my mind was wandering elsewhere, but was still focused on LD.
Yeah, and as you say, Lisa, I think it's the outcomes we want of the health check, not just the health check itself, that's so important. And certainly having done learning disability health checks for a number of years, that is the bit that you really want to feel that someone has an understanding of. It's what happens between that health check and the next one that is going to determine whether somebody gets a positive outcome of having turned up. And there are so many factors in that, including good communication, getting the understanding, and getting a plan that's right and is understood and owned by the person who's there in the context of the people who care for them for the rest of the year.
Yeah.
Simon.
Okay. Thank you very much. Second question then, in relation to the development of an anti-bullying strategy that in another meeting support for the view that the current coping with bullying is an unacceptable approach, would you confirm to rule out any consideration of the, in brackets, nonsense, close brackets, concept, unconscious bullying?
I think I'll have a poke at this one. So I think there's a few things that this raises to me. So bullying, yeah, absolutely isn't about how do we create resilience to everyone to bullying, but actually more around how do we make the workplace an enjoyable place where issues that need to be raised can be raised as a matter of course, not people thinking that it's risky to raise them. You know, but bullying comes in all sorts of ways. You know, it's not just overt physical threat. It's psychological. It's the words we use. It's the method that we may use to deliver the words that can have a negative impact. You know, the phrases of gaslighting, of coercive control are common to those of us in practice in terms of trying to understand where people are in threatening places. But in the workplace, it is so essential that we have an anti-bullying culture and one that is supportive of people being able to say what they need to say. There are ways and means in which the NHS supports this through the whistleblowing policies. We might say that having to have a whistleblowing policy is a bit sad, because actually what we want is that supportive workplace in the first place. In terms of unconscious bullying, my experience, I'll give my personal view and I'll invite comment from others. My personal experience is that I really think that it exists, because I have come across people who hold very strong beliefs about the purpose they have and that the ends that they're striving to achieve. But when that's linked to a lack of personal insight on the means with which they're deploying to get to those ends, I think that does put people at risk of being unconscious in their bullying. And strong leadership, which we all aspire to have, I think needs really well-honed personal insight that can only be derived really from seeking feedback and then acting on it, and doing that regularly. And I think that's the culture that we certainly would wish to aspire to support. Don't know what other people think.
I'm not sure I can add to that, Mark. I think just we need to have a culture where it's doesn't take place and is never acceptable.
Yeah, I mean, there's a Deming principle about driving out fear. That if you've got fear in the workplace, you'll get answers that you are expecting, not answers that are necessarily real. And so if you translate that into a medical environment, then you're going to be at risk of doing the wrong thing for somebody and putting them at risk as a consequence. But that's just as translatable into any any role that somebody has, the consequences of making the wrong decision based on information that's given because somebody's fearful about what they're saying isn't going to match the expectation of who they're saying it to, is it, you know, it's not worth thinking about. And I think that public standards, or, you know, the standards in public life, the Nolan principles, I think they derived from a place where trust is needed and needed to be seen to be in place, not just perceived. And I think they stand us in good stead.
Okay, thanks, Mark. Third question then from Mr. Dooley this afternoon. Do you consider your CCG presentation about the future of mental health to the Health and Wellbeing Board meeting recently that made no reference to coronavirus was an example of a performance by an outstanding CCG?
Richard, do you want to start?
So I was part of the Health and Wellbeing Board, and I think the system gave an incredibly powerful set of presentations around the work that we have underway around mental health and emotional wellbeing, and some of that I showcased earlier today, but I think even wider than that, the role that the voluntary care sector is playing, our county council and others. So no, I think there's a huge amount to do, but I think it was a really positive show of, yes, there is a huge amount that we need to be doing as a result of COVID-19, but actually we have carried on this programme regardless. A lot of the work, yes, has been slightly impacted, but we needed to get on with it, which we've done.
Thanks, Richard.
Yeah, I think I would strongly agree, Richard. And I mean, the presentation, I think, isn't so much that it was a CCG presentation. I think it was a partnership presentation. And the derivation of this mental health work comes from a co-produced piece, an amazing piece of co-production that was done with the hashtag A Very Different Conversation. So I think the derivation of it and the way that it has gone from co-production through a collaborative development, public sector, voluntary sector, GP membership, I think was reflected really well in the presentation that was given. There's a question around, does coronavirus, did it need to be specifically mentioned? And I think the outcomes that we're looking to achieve here with this transformation programme is, yes, about the impact that coronavirus will have in our communities for many years to come, and are we prepared to be able to manage that from a mental health perspective? But I think it's really more about whatever our communities are under stress from, can we be in a position as a CCG supporting the best use of assets with all of our partners to manage that need? Then I think my answer is yes, that's exactly what it was about. So my answer is yes.
Thanks, Mark and Richard. The fourth question then from Anthony Dooley. I didn't catch the details of the performance of ESEC referred to by Paul. Could they be clarified in the final section?
Happy to, if that's all right, Mark. I simply stated that clearly there was slight deterioration in the transport KPIs that we are looking at. I suspect and know that is in part due to the COVID transport issue, i.e. being able to transport less patients than they were able on one transport unit, and that we were looking to see at ways we could support ESEC through this winter and COVID period. And that's all the statement I made. Hope that clarifies.
Okay, thanks very much. And just one final comment now from Alan Rose. He's written, it's a patient representative. He said, thank you for the constructive discussion this morning of the Felixstowe MIC and ageing world developments. And those were the comments and questions received. Thank you.
Thank you very much, Simon. Now that we're concluded with all of the questions, I'd like to thank you for the attention that you've given us and the questions you posed us and the observations. Thank you very much. And we'll meet again on the 26th of January 2021. So thank you all. The rest of the governing body, we've got a part 2, so I will see you very shortly. Thank you very much. Bye now.
Bye.